Hi, this is the Symposium Orthogeriatrics Concepts, Challenges and Answers, organized by the ALMA, Latin American Academy of Medicine for the Older Adult, by its acronym in Spanish, and the FFN Fragility Fracture Network. I am Dr. José Luis Dinamarca. I am a Chilean geriatrician and PhD, and I will chair it for you. First of all, and before I present our speakers, I want to address and highlight briefly two important concepts: the orthogeriatric cycle and the 4 pillars strategy. This will allow us to have an overview of our symposium. The orthogeriatrics clinical cycle comprises 4 main phases. In each of them, we can carry out specific interventions, and all are interrelated in a continuum. The first one is the promotion and prevention phase, focused on the education of the population and on the diagnosis and treatment of risk factors. The second one is the acute phase, focused on the acute institutional management of people with fragility fractures, followed by the third one, the discharge phase, focused on returning patients to their usual environment. And the last one, completing this cycle, is the follow-up phase, includes the actions implemented to favor the correct evolution of the patients over time. In parallel, the way in which these stages are implemented leads us to the 4 pillars of orthogeriatrics. This is a global strategy to achieve changes in every goals to be addressed. The first pillar is the acute multidisciplinary care for people who suffer fragility fractures. The second one is the rehabilitation and ongoing post-acute care, aiming to restore function, independence, and quality of life. The third pillar is the secondary prevention after all fragility fractures. And the last one, the politics. It includes alliances between relevant professional associations to achieve necessary changes in healthcare policy and promote best practice among colleagues. In this symposium, we will address first the prevention of fragility fractures by Dr. Geraldine ALTAMAR from Colombia. This will be included in the promotion and prevention phase of the orthogeriatric cycle and in the third pillar. After that, Dr. Juan Viveros from Mexico will address links between acute phase and record systems in the first pillar and in the acute phase of the orthogeriatric cycle. And finally, Professor David MARSH from the United Kingdom and Italy will address the importance of organizations to politic changes. This is included in the 4th pillar and in all the orthogeriatric cycle. Due to the importance of this group of pathologies, the ALMA and the Fragility Fracture Network start an important alliance, and one of its products is the symposium. Please send us your questions. Welcome and enjoy.
Hi everyone, this is Maria. She's a healthy 70-year-old woman and she doesn't think maybe she's at risk of fragility fractures. This is Eva. Eva has suffered her second fragility fracture in her life. My name is Geraldine ALTAMAR. I'm going to talk about prevention of fragility fractures. I'm a geriatrician and work at Orthogeriatric Unit in Cali, Colombia. These are our objectives of presentation: recognize, understand, and identify the evidence of fragility fractures. Remember, osteoporosis is a generalized bone disease that leads to low bone density, poor clarity, and increased risk of fractures. So, fragile fractures are the clinical outcome of osteoporosis. These are low-energy trauma fractures. When the load-bearing capacity of bone is exceeded by force because of reduced bone mineral density, bone geometry, and microstructure and quality. So, older patients with fractures are suffering fragility from bone and frailty in a geriatric syndrome of low biological reserve. The most common sites are the hip, spine, and wrist. However, they might occur in any both of appendicular and axial skeleton and generate consequences in loss of functionality, increase in morbidity, and increase in mortality. Fragile fracture pattern varies with age. At 50 years age, forearm and vertebral fractures are more frequently. And age 85 and over, hip and humerus, proximal humerus, spine, and forearm in this order are more frequently fractures. Remember, when I have a fragile fracture, there is an imminent risk after this fracture in between 12 and 24 months after the first fracture. So we have to treat these fractures. We have to do secondary prevention of the next fracture. And the history of fracture is a strong risk factor for future fractures and increase with your age or with our patient age. So, fragile fractures generate socioeconomic burden in our patients, our system of health. Fractures affect quality life, degenerates functional capacity, loss of independence, loss of self-esteem, and accelerates morbid mortality. Hip fractures is the worst fragile fractures. It goes to patients with hip fractures, goes to functional decline, institutionalization, and accelerates mortality. These are enormous health costs, significant health costs in our countries as consequences of fragile fractures. So we have to treat fragile fractures, but the care gap in fragile fracture. The care gap is the discrepancy between eligible patients and patients actually treated. And this is the reason because the care gap exists from the unknowledge of osteoporosis and as a chronic disease who generates fragile fractures, lack of prescription, never learn about the underlying cause of the fractures, concern about polypharmacy, or when the fragile fracture presents, all the actors doesn't think about the treatment. Primary care physicians don't investigate the patients. Orthopedic surgeons do not initiate investigation in hospitality setting, or hospital-based osteoporosis specialists are unlikely to interact with the patient when the patient goes to primary care. These are factors for no attendance in the care gap: the male gender, frailty, living alone, low education, no interest in bone strength, or being unaware of the subsequent fractures. So the goal is the prevention of fragile fractures, primary prevention or secondary prevention. The most cost-effective fracture is hip fractures, but when we have a first hip fracture, the 50% probability of our patient has another fragile fractures. There is a two pragmatic approach to prevention, primary fracture prevention. First, global intervention is fracture risk prevention and systematic application of tools like FRAX, and individual preventions. Individual prevention in high fracture risk patients by searching of osteoporosis induced by medications and disease associated at low mineral density. In this systematic review and meta-analysis show a significant reduction of osteoporosis fracture by 5% using a fracture risk assessment and bone densitometry compared with usual care, and how population screening is effective to reduce osteoporotic fracture, major osteoporotic fractures by 9% and 20% of hip fractures. The numbers needed to screen to prevent one fractures are 247 for osteoporotic fractures and 272 hip fractures, corresponding to 113 bone densitometry examination and 124 to prevent one hip fracture. It's more than you need to screen for colon cancer, for example. So, screening of population is cost effective. Secondary fracture prevent occurs when you have a first fragile fractures. You have to reduction of refractures, improve to quality of life, and reduction of recurrent falls. How? With timely and effective identification of fragile fracture risk and ensure adequate osteoporosis treatment. These are our advice about secondary prevention. Always communicate to patient and family the risk factors, the healing process, and how to prevent the next fractures. Second, always patients have to receive pharmacological treatment. This is the last guide of osteoporosis pharmacological treatment. And we have to do immediately short-term treatments and consider anabolic treatment followed by inhibitor of bone resorption, because we have an immediate risk of the next fracture. And these are our suggestions for optimized calcium and vitamin D intake in all patients with after recent fractures. There is two models of secondary prevention fractures: orthogeriatric care service and fracture liaison service. Orthogeriatric services are orthogeriatric co-management with coordination of multidisciplinary teamwork with a co-leader in orthopedic surgeon and geriatricians, work with anesthesiologists, physiotherapists, social workers, nutritionists in all the phase to attend especially hip fractures from emergency room to rehabilitation. In this meta-analysis and a systematic review found a low and moderate quality evidence that orthogeriatric care is possibly associated with supplementation with calcium and vitamin D as discharge, initiation of therapy for osteoporosis and discharge, diagnosis of osteoporosis, and specifically in hip fracture, reduce length of hospital stay, lowering hospital mortality and mortality at first year, and risk of delirium and fewer complications, but is not evidence in time to surgery and readmission rate at 30 days, and no consistent effects in functional outcome. The second strategy is fragile liaison services. The purpose is ensure that all patients at 50 or more with fragile fractures undergo to fracture risk assessment and receive adequate treatment by identification, investigation, intervention, and information to the patients, doctors, and patients. It's a model based on fracture coordinator as pivotal player. Orthogeriatric services and fracture liaison service are complementary. We have to treatment hip fractures, and we have to look after the all fractures, and we have to prevent the next fractures. This is in this meta-analysis and review shows our benefits of FLS. Increase BMD testing, increase adherence to treatment, initiation of treatment, reduce refracture rates, and reduce mortality. As I said before, orthopedic services and FLS are components of a systematic approach who looks after reduce the first and the next fractures, prevent frailty, preserve bone health, ensure treatments, ensure capacity functional of patients. So, but it's not only the full integration is FLS and orthogeriatric services. The change must play out the political level where all the actors, medical associations, patient associations, stakeholders, insurement, all of us, we must understand and accept the extent of the problem. How to FFN calls it global call actions now turn to actual actions. Where is the future? Bueno, this is a rapid review about use and digital technology management in osteoporosis. Evidence suggests that digital technologies support multidisciplinary teams to provide the best possible care and current evidence. To take home messages, fractures affect quality of life. We have to treatment our patients. We have to do secondary fracture prevention should start early after the first fracture occurs. The treatment is comprehensive. Communicate risk, drug treatment, adequate calcium, vitamin D, nutrition, and fall preventions. And we have to work in FLS and orthogeriatric cares. We have to work all the actors, medical, patients, stakeholders, to a most effective approach to prevent first and secondary fracture preventions. This is my email, and if you scan this QR code, you have all the bibliography of this presentation. Good day.
Thank you very much. My name is Juan Carlos Viveros. I'm an internal medicine physician, geriatrician, and I have a fellowship in orthogeriatrics. I work in León, Guanajuato, Mexico, in the hospital of ISTE, which is a working government facility. I've been invited by José Luis and Alma and the FFN to speak with you about the links between acute management, hip fracture audits, and how these have been a game changer in the quality of care of patients with fragility fractures. The main objectives of the lecture is to know the objectives and methodology of the most important fractures audits worldwide, show some results of hip fracture audits, what have been done in Europe and in Latin America, and how these audits and registries have helped to improve quality of care of patients with hip fractures. These are one of the most important hip fracture audits. Australia and New Zealand launched it many years ago. The National Hip Fracture Database in England, the Spanish registry have made outstanding work in the last years. They also achieved one of the World Health Organization awards recently. And we work in Mexico to try to launch the Mexican hip fracture audit, which at this moment is restarting after the COVID pandemic. So this is one of the examples of hip fracture audits. And what are the main objectives of these hip fracture audits? What was the starting point of them is to know the socio-demographic, epidemiologic, healthcare process and outcomes of hip fracture audits. Continuous collection of data, benchmarking, try to know where are we standing in terms of key performance indicators, and monitor quality of care and healthcare improvement. Most of the audits worldwide, they have been working in this chart of variables. Is the minimum common data set suggested by the Fragility Fracture Network. Recently, there's been a publication with amendment of these variables, try to make it a little lighter for economics in emerging countries. But the main These points are gender, age, the mobility status before the fracture, mental status, surgical risk, the type of fracture, if they had or not osteoporosis treatment, and the functional status. Most of the data also are collected in the in-hospital facility, date and time of the emergency room arrival, date and time of the admission to orthopedic ward, if they develop sore ulcers or delirium or another complication, if they what's the main of the average of the surgical delay, and the discharge information, if they were discharged to their own homes or to a long-term care, and also a 30 days follow-up of the same variables. So the benchmarking, it's also important. The National Hip Fracture Database results give us a map where we can compare the performance of the indicators between hospitals, and they will give us a very good idea of where we're standing in our own hospital and how to try to improve comparing to other hospitals. Also, the other part that's important is the key performance indicators. The Spanish team proposed recently a bunch of key performance indicators. In Mexico, we are working at this moment in another, trying to adapt these indicators for the Mexican population. So key performance indicators is one of the most important parts of hip fracture audits. The main results of the most important hip fracture audits, for example, in England, 99% of the patients, they are evaluated by a geriatrician. They have 73% of early surgery. They're very compliant to the recommendations of the type of fracture and the type of implant that will be applying to the patient. Most of them have early mobilization, and they have a very good rate of non-delirious patient in the postoperative rate. They also have in England, they're in Scotland, sorry, they take the key performance indicators from delirium, they also trying to improve in the blockage of the fascia iliaca for the analgesic procedures. Australia and New Zealand, most of them, they're seen by a geriatrician. They also have a very good rate of low complication, early mobilization rates. And this diagram in the Spanish registry, I think it's beautiful. It's a collaboration from Cristina Ojeda, which is also his speaker in this Congress. And they improve the length of stay, the mobilization, the early surgery, and they decrease the complications as sore ulcers or delirium, also mortality too. If we compare Latin America, where we're standing and the key performance indicators, for example, we may notice that the main average of surgical delay in Mexico is a lot higher than in other countries, 75 hours in Spain to 194 hours in Mexico. We're trying to improve this rate. Early surgery also, it's important. 40 hours, 40% of early surgery in Spain, 70% in the UK, only 10% in Mexico. The geriatrician assessment also, it's important, 94% in Spanish, 91% in England. And the complications and mortality also were higher in Latin America. So where we're standing in Latin America, Mexican hip fracture audit was launched in 2018. We tried to engage some hospitals after the pilot phase, and then we have to stop after the development of 2019 because of COVID. Recently, we started again with the endorsement of the National Society of Orthopedic Surgeons, which is trying to increase the number of hip fracture patients included in the audit. Also, the other Latin American country which is pushing very hard is Argentina. They are almost launching the Argentina hip fracture audit. It's led by Maria Diels, who is making outstanding work. And recently, a team of Uruguay reported that they are starting to think about developing a national audit. So In Latin America, we're starting to make some noise too. We're trying to follow the steps of European countries. And we noticed that hip fracture audits will give us a lot of information considering where we're standing and how to improve. If we see the charts in Ireland, they also made some analysis between 2005 and 2018, and they managed to improve the mortality, the key performance indicators performance too. So key fracture audits, they are useful. This is one of the key performance indicators that I mentioned you before. Patients operating less than 48 hours, try to mobilize early out of bed in the day after the surgery to receive osteoporosis treatment, supplementation of calcium and vitamin D. Also, the rate of patients who are receiving or developing sore ulcers, and the prevention is also delirium too. Another important role in the performance indicators improvement and the quality of care was the pay for performance, or what is called the best practice tariff, which is a development or initiative of the government, tried to pay for to hospitals and to physicians if they achieve a standard of care and a compliance to key performance indicators. So most of them achieve to have a statistically significant improvement after the development of the best practice tariffs too. So if you see on this paper from Ireland, they managed to improve the admission to the urgent ward from 15 to 17% in 5 years. So the early surgery, it also went up. The development of sore ulcers was going down, and the geriatrician approach was going up. The bone assessment was going up, and the false assessment as well went from 62 to 70%. So if you take a deep look in all the papers and the publications, most of them help us to improve quality of care. England, they managed from 2003 to 2011 to decrease 30, 90, and 1 year mortality after the development and the launching of the National Hip Fracture Database. It was a very important tool to try to approach or get nearer to the geriatricians and the orthopedic community. So it was a very good idea to try to work them, to make them work together after the National Hip Fracture Database. So this pay for performance is a good idea in economic developed countries, but maybe not so suitable for economic countries like in Latin America. Maybe we should try to find another way to manage how to improve quality of care in our own countries. So for the conclusion, we should say that hip fracture audits are centered in quality improvement, and that must be the most important part of fragility fracture audits. The development of these audits should be the standard of health ministers worldwide. It will give us a lot of information where we're standing, what are the points of opportunity, and they will put in the perspective all the key performance indicators. These public policies, such as best practice tariffs, are pillars in the improvement of care. We should try to find a way to motivate the stakeholders in the hospitals and also the actors in each one of our hospitals to try to follow this compliance to key performance indicators. And I am quite sure that Latin America is now prepared for more audits. The Fragility Fracture Network and LANMA are great allies in the process, and we are always open for helping you, any person who is interested in launching their own registry or audit, how to go all through the process with our very, very, very little experience. So thank you very much.
Good morning. My name is David Marsh, and I'm a retired professor of orthopedics. I want to describe to you the Fragility Fracture Network, which is a global organization dedicated to promoting orthogeriatric co-management of fragility fracture patients. Why does the FFN exist? The answer is because of this epidemiological emergency due to the aging of the population in all countries. Despite the fact that the age-specific incidence of fragility fractures may be falling in some countries, this is far outweighed by the aging of the population. And we are going to see massive numbers of hip fractures and other fragility fractures in the coming decades, a doubling in the established economies and up to six-fold increase in the emerging economies. And in all countries, current systems will not be able to cope with this increased incidence. So the FFN was founded in 2011 precisely to address this challenge. So what does the world need in relation to fragility fractures? I would identify three key things: development of the workforce, changes of healthcare policy, and the ability to share experience. And the FFN can help these to be achieved, and I'd like to explain how, working on a global level and a national level, and building national multidisciplinary alliances. We also have several guides to action, which are useful tools for driving things forward. What about workforce development? The trouble is that we need three clinical pillars of orthogeriatric management: the co-management of the acute fracture episode, good quality rehabilitation to regain function and independence and quality of life, and reliable secondary prevention after every fragility fracture to prevent the next one. But the workforce needed to deliver these types of these things requires healthcare professionals that are currently in rather short supply. We need more geriatricians or other physicians with geriatric competencies. We need specialist nurses who can assist with orthogeriatric co-management. We need better rehabilitation and physiotherapy, particularly in the community. And we need a great expansion of the number of fracture prevention practitioners who can staff FLS clinics that can take care of all fragility fracture patients. Making this happen at scale requires policy change in any given healthcare system. Individual hospitals can put together teams based on a few champions, but to do it across a country requires top-down pressure that clinicians and hospital managers will respond to. And things such as national standards, financial incentives, and requirements for performance measurement are all powerful drivers of large-scale change. And in order to achieve such policy changes, we need to have many disciplines speaking to power with one unified voice. Sharing experience is vital because things are happening too fast. We do not have the luxury of enough time for everyone to find their own way, rediscovering the wheel. There has been an enormous accumulation of experience, and we have to accelerate development by sharing that experience and applying lessons that others have learned in setting up this acute care, the long-term community-based systems for falls prevention, ensuring compliance and supporting caregivers, the provision of fracture liaison services that cover all fragility fractures, and quality control mechanisms such as hip fracture registries. There's a huge international experience and we need to share it. So what the Fragility Fracture Network stands for was described in this paper in Injury in 2018. This paper was co-authored by a number of important organizations, and the process was led by the FFN. The contents of this global call to action to improve the care of people with fragility fractures can be summarized as 4 pillars, of which the first 3 are clinical. And they're the things I've already mentioned: the multidisciplinary acute care on orthogeriatric lines, taking care of frailty as well as the fragility of the bone, rehabilitation to regain function, secondary prevention to prevent the next fracture. And then the fourth pillar I'll come to in a minute is multidisciplinary national alliances. So how can we help to promote the implementation of this call to action, turning it into actual action? We don't want this to sit on a shelf gathering dust, as so many previous calls to action have done. And the answer is we have a regionalization strategy involving the formation of national FFNs who turn this call into actual action and perform a lot of the educational needs to develop the workforce in each country. Our global and regional meetings are important. They are inspirational, showing how people have overcome challenges very similar to the ones that you face now in your country and your hospital, and giving you the opportunity to share your success. However, bringing about a large-scale workforce development and changes in healthcare policy can only be done on a national level, inside a given national health service. And that's the reason for the fourth political pillar. We've adapted our structures to recognize this through the strategy of regionalization, meaning the creation of national FFNs dedicated to achieving this real change. There are now 24 national FFNs across the world, 14 in Asia Pacific, 1 in the Middle East, 7 in Europe, and 1 in Latin America. And we're working on the United States at the moment with the International Geriatric Fracture Society. What do these national FFNs do? Well, they work through the existing monodisciplinary associations, the National Geriatrics Association, the National Orthopedic Association. We're not there to compete with those organizations, but rather to facilitate collaboration between them. And this is all about building these national multidisciplinary alliances that speak with one voice to power. It's essential because if one profession approaches the government, one discipline with their professional association approaches the government and asks for resources, it is automatically assumed that they are speaking from self-interest. But if many organizations speak with one voice, they are far more likely to be listened to. So the national FFNs, bringing together the leaders of the national associations, should set goals for healthcare policy change, boosting those 3 clinical pillars and pushing for the necessary resources and standards, financial incentives and registries, etc. And their next job is to develop the workforce through education, multidisciplinary education, multi-professional education, teaching orthogeriatric competencies and what nurses and physios need to know about fragility fractures. The global organization of this strategy is here. You can see in the top left, there is the global call to action with the 4 pillars. And down in the bottom right, you can see implementation of them. And the regionalization committee of the global FFN coordinates the work of 3 regional committees in the 3 big time zones of the world: Asia Pacific, the Americas, and Europe. And each regional committee coordinates the work of the national FFNs in that region, and they work on the national activities in association with the national professional associations representatives. They lead and they coordinate the derivation of guidelines and standards, the development of workforce, the creation of registries where that's helpful, and the instigation of policy change. And the global FFN has these working subcommittees: regionalization, education, communication, and the scientific committee, along with special interest groups such as the Hip Fracture Audit Special Interest Group, to give support to the regions. FFN has got some tools which can help people to get started if they're not already started. For each of the clinical pillars, this toolkit gives evidence just to back up the rationale of having them, the clinical and cost effectiveness, methods for mapping current pathways, and then making stepwise implementation of better pathways, how to set up benchmarking with guidelines and standards and registries, etc., how to involve patients, and what resources are needed. And this is free to download in several different languages from the website, the FFN website. Then there is the policy toolkit. This is also available free in several languages, and it gives guidance on successful implementation of the fourth pillar: policy engagement, useful templates for business cases and job descriptions, case studies showing how problems have been overcome in different places around the world, and many additional resources. In more detail, we have a textbook of orthogeriatrics, which is now in its second edition, free to access, and it is published only 2 years ago, and it has had nearly 300,000 chapter downloads so far. It is our distilled knowledge about everything to do with the post-fracture pathway. Translations into several languages, and you can easily find it by Googling orthogeriatrics Springer. Then we have the guide to formation of national FFNs, how to set them up, why they're needed, how they work best, and the sort of goals and projects that they can initiate in any given country. So in summary, our purpose is to empower healthcare professionals who've woken up to the challenge of fragility fractures and are prepared to act as champions, with a clear manifesto of upgrading clinical systems and skills to provide adequate management of the 3 clinical pillars. Regionalization with the creation of national FFNs is the way to make this a reality on a global scale. And the global organization keeps everyone on message. Thank you very much for your attention.
Well, thank you very much for your attention and your interest in this ALMA and FFN symposium in fragility fractures. It's a real pleasure for me to work with these friends and colleagues, and I would like to welcome Juan Viveros from Mexico, David Marsh from the United Kingdom, but from Italy now, and Geraldine ALTAMAR from Colombia. Thank you again, friends, because this is a hard but interesting work. And it's more when we can work with friends. During this question and answer session, you can see in your screens a pop-up, and if you link that pop-up, you will be able to download a conceptual document which resume the concepts of this symposium. I am not able to see it because I am in another part of the organizational rooms, but if you can't download it, please send an email to the organizational committee because it's for free and we prepare it for you. Well, when I started my PhD in Granada, Spain in 2008, and started working in orthogeriatrics and hip fractures especially, you search on the PubMed orthogeriatrics and hip fractures, and you have in return around 300 papers. Now, if you try, you will have over 5,000 and weekly we have lots of papers. So there are lots of papers, lots of information, lots of experiences. And that is because our first question is exactly about that. How we could resume practically to start working in orthogeriatrics, to start making it possible in our own realities. And Gerald, it's possible to give us such a kind of ABC about secondary prevention and secondary pharmacological prevention in fragility fractures.
Okay, Jose, hi, everybody. Okay, this ABC on 1, 2, 3. First, fragility fracture is osteoporosis fracture. You must have to treatment patient. Pharmacological treatment is necessary. When you have a hip fracture, you have to operate this patient 48 hours in the first 48 hours. And when the patient is discharged, you have to give pharmacological treatment, prevent falls, and impact in quality, health quality. But you have always communicate to the patients, to the caregivers, to your staff, what is the impact of the osteoporosis fracture. And this is ABC. And first,
So
you have to believe in fracture. If you don't believe in fragility fracture, if you don't believe the impact of fragility fracture, you can work in fragility fracture. If you think it's an aged problem, you don't believe in fragility fracture, you can work in fragility fracture and you can prevent, and you can do secondary prevention.
So you must start to be a believer. And the C of this ABC that you give us is to start ever working with the caregivers. That is a very, very important message. So you can't work just with the patient or just with the health team. You must include the caregiver, isn't it? Well, from the science, we must move to the clinical experience. And the clinical experience, the daily quotidian experience, must be transformed in data. Databases are absolutely important to improve our clinical daily work. And that is because I want to ask Juan Carlos if, Juanca, could you please tell us about how are the local Latin American systems of registries about hip fractures?
Well, I am also a believer that information and measurement are important. What's not measured, it's not suitable for improvement. So we need to measure. My suggestion and the thing that we started doing in from small to big is to measure small quantity of data. Most of the key performance indicators that are suitable for improvement in my hospital, like surgical delay or mobilization after surgery. So try to start small and then build some assets and activists from other hospitals, some friends of yourself or colleagues that maybe will or are willing to use your own data, and then it will come bigger and bigger and bigger. If you are well organized, maybe you can knock the door of the orthopedic societies and the geriatrician societies to build a network like the one is building in Argentina, which it's, in my opinion, the best organized audit in Latin America at this moment. So it is important to measure. Data are important too. They are going to give you information for quality improvement, and you need to have an orthopedic surgeon and a geriatrician on the board or the top of the process since day one.
And like football players. Greetings to Bruno Boyetti, Javier Benchimol, our friend from Rafka. You are very organized, guys.
Well, this is a very interesting thing. It's absolutely possible to start working and develop an interesting database. Like Juan Carlos says, it's easier for us in Latin America and stronger to start working with your local data. And since that, develop your databases, national databases. But there are some very important things in the main picture. So it's absolutely important also to have organizations that have the big picture clear. And that is why we have organizations like the FFN and the ALMA. So I would like to ask you, Dave, what role should a national FFN play in relation to the mainstream professional associations in the same country?
Well, let me start by reporting what happened in the United Kingdom back in the first decade of this century. We started with a national hip fracture database project, and we were doing that primarily in order to generate data, as Juan Carlos was saying, which would be powerful in allowing us, in persuading the government to improve our facilities. But what we discovered was that in the process of spreading the national hip fracture database, going to different hospitals and talking to the staff who looked after hip fractures, and going to the government and asking for funding, at the same time as capturing data, we were also spreading the concept of orthogeriatrics, the combined management between orthopedics that knows how to fix the bones and geriatrics that knows how to handle the frailty. And the big thing that happened was that the British Orthopaedic Association and the British Geriatric Society signed a memorandum of understanding that they were going to work together to create an atmosphere of orthogeriatric co-management. And what was interesting was that the number of activists in each of those organizations that were responsible for driving that was very, very small. It was just a few people, because what we were asking our respective councils to do is so obviously sensible and so obviously right that we never had to fight for it. And we were able to speak from day one in the name of the British Geriatric Society and the British Orthopaedic Association. Now, this actually happened before the FFN existed. But actually, the reason the FFN exists is because we learned that lesson in the UK. That if you speak with one voice to the powers that be, speaking on behalf of both orthopedics and geriatrics, then you get results. But we didn't go along there saying, this is us. We went along saying, this is the British Geriatric Society and the British Orthopaedic Association. These are the big guns. So this is what I think a national FFN now needs to do in this day and age. You need to have in your national FFN leading voices from the mainstream professional associations, and you need to get permission from them, these powerful professional associations. You need to get their agreement that what you're going to advocate, or what they're going to advocate, is orthogeriatric co-management. And you don't need a very big national FFN to do this. You just need the right people in the national FFN who can get the respective governing bodies of the relevant professional associations to agree what they're going to fight for, which is multidisciplinary care for people with fragility fractures. So that's the way round, as far as I'm concerned, is that the FFN, the national FFN, is the catalyst. The main explosive is the professional bodies.
Thank you, David. Well, we have received a very practical question, and it's about vitamin D. So it's an open question. Which is the importance of vitamin D to prevent fragility fractures? And I would like to start saying that you must think that vitamin D is not just a vitamin, but a hormone. So you have receptors all over the body. If you have normal levels of vitamin D, you will improve all your health, not just prevent fragility fractures. So, fellows, what do you want to say about this?
I think that Geraldine is the most qualified of us to speak about vitamin D.
Oh, Juan, thank you. Well, when you remember the study of Bessie Dawson-Hughes from the 20s, doses from over 800 units from vitamin D reduce fragile fractures and falls. Values from over 39 degrees for milliliters. I don't know, numbers is confusing for me to Spanish to English. José, please help me. Por encima de 30 nanogramos por mililitro de niveles séricos de vitamina D, over 30 nanograms per milliliters of 25 hydroxy-vitamin D, we reduce fragile fractures and falls. When you don't have a first fragile fracture, when you have a first fragile fracture, it's almost confusing because the evidence is a moderate evidence. But we know we have over 100 units. You must take over 100 units. You must to have over 40 or 50 for another studies, or 9 grams of milliliters of vitamin seric, value seric, and you and that's all. And with calcium, 102 milligramos de calcium. Sorry with the numbers, guys. José, please.
1,200 milligrams of calcium. Thank you, Gerald. So,
may I add something, José Luis? Well,
Okay,
if you look backward in all the original trials of osteoporosis treatment, every single one of them is the drug plus calcium plus vitamin D. So it's like by default to think that we should encourage people to give anti-osteoporosis treatment plus calcium plus vitamin D.
That's interesting what Juan says, because the first studies you must the first studies are doing with calcium 1,200 milligramos, 1,200 milligrams, and they don't measure vitamin D. But now with the new anabolics, they measure vitamin D. If you have less than 40 nanograms milliliters, you have to take 50,000 of vitamin D to increase to the study. That is so important you have inadequate levels in your injection of calcium and vitamin D. It's so important.
guys, in honor of the time, I must say goodbye to Geraldine, ALTAMAR, Juan Carlos Viveros, and David MARSH. And I would like to say, do you want to start working in orthogeriatrics in a practical way in your workplace? You can start local hip fracture registry. Do you want to carry out an impact action in your clinical pathway? start pharmacological and non-pharmacological prevention? And do you want to work without feeling alone? Join the FFN for free and you will have a community to help you achieve your goals. Thank you very much and farewell.